critical appraisal of a cohort study on harm. Just a scenario. So suppose a 65-year-old gentleman who's a non-smoker, diagnosed COPD, and also a diabetic, come to your OPD with a neuropathic pain. Now, we have on OPD basis, we plan to start on a gabapentin, which is mostly a common drug we usually start in our OPD basis. Now the question for us is, does gabapentin increases the risk of severe exacerbation in COPD? We have found a journal in Annals of Internal Medicine. It's a cohort on gabapentinoid and association of gabapentinoid with the risk of severe exacerbation of COPD. For a study on harm, there are four parts of doing it. Mainly, we did they address a correct, clear and correct question in the whole system. After that, whether the risk of bias, how serious was the risk of bias, what are the results, and how can I apply this to my patient population. I will start with whether they have addressed a clear question. So the question they focus on, does the gabapentin use increases the risk of severe exacerbated COPD? What are the patients they have, for the PICO statement, what are the patients they have included in the study, which is, so they have taken all the patients from 1995 to 2004 from Canada. So what they have done is, how they recruited was, they have gone through the medical registry of 3 hospitals and see who all were on LAMA, LABA or ICS inhalers along with oral bronchodilators. But the problem with the inclusion was they did not fully use it's ICD. They did not fully use the ICD codes to get the diagnosis of COPD. They had just checked who all were on inhalers from these 20 days and anywhere mentioned in the report whether they were on they were a COPD patient or not, but they were all not diagnosed COPD patients. It was all according to the medication use. So there could have been some inclusion of some other disease also in it, can be a possibility. Exposure was initiating gabapentin. Again, exposure was calculated by looking at the prescription when and where gabapentin was initiated and what was the indication. Control were people with similar characters, COPD, but not on gabapentin, non-users in COPD. Outcome was looking for severe exacerbation of COPD. I will come to the outcome later. And it was a cohort study. Now, when you look at a study for looking at the etiology or harm, the best study to do itself is cohort or a case control. And we have done a cohort in this study. Now, how serious is the risk of bias? So what we look at this is, now we are initiating a treatment or an intervention or an exposure and looking at whether there was an outcome due to it. So what we need to know is, through the course, whether there was any other added factor aside from the exposure of interest. Did they have any other exposure, any other intervention that could have caused this? So what they have done is, they have matched each gabapentin treatment of the intervention group with the control group, and while recruiting itself, they have matched everyone with the indication of gabapentin, that was either epilepsy, chronic pain or neuropathic pain, the COPD duration, age and gender, and when they were recruited, so that there will be less other confounders will be less when they were matched initially, so the confounders will be less. However, variables which I would be interested in a case like this would have been, what was the vaccination status, what was their smoking history, whether reform smokers or active smokers, which was never included in the baseline characters, or while matching they are not included. So there could have been some form of residual confounders in the intervention if they were smoking, or whether they have recurrent illness because of unvaccinated status. They could have had more exacerbation and not just a gabapentin. Just going through the baseline characters. Otherwise, they are matched with age and gender. Whether they had any severe pneumonia in the past, whether the exacerbation, the treatment, that is something else. Again, if they were inadequately, if they are class A, B or E, and if they are inadequately treated, again that also could have had an exacerbation and not just gabapentin. But most of them were matched equally in the baseline, were matched equally with all the set of treatments they were on. Including the underlying comorbidities. or except CKD, most of the commodities matched, and in CKD also, gabapentin users were 25% CKD and 18% in the epilepsy arm. However, CKD itself might not be a direct risk factor to cause a COPD exacerbation. So I would say this, maybe we can allow this much change in a COPD case, in a CKD. So then the next question is, were the circumstances and methods of detecting the outcome similar? So this is something called a detection bias or a measurement bias. Now here, what are the outcome we are thinking of? The outcome is the first hospitalization with an admission or a diagnosis of COPD follow-up during the COPD follow-up and or a death due to COPD exacerbation. Now and secondary outcome is just sending them back on oral prednisolone during an exacerbation. Now the problem in this is they have mentioned they have tagged people as a severe exacerbation who are got admitted, but what was the criteria for admission on a patient they have not mentioned, or what is the criteria for discharge on oral prednisolone also they have not mentioned. So whether they have included, if I knew the if I was one of the part of the study and if I want to admit everyone, I can actually give them an admission even though they required only an oral prednisolone. So what was the criteria among all the 3 hospitals for a COPD exacerbation was not mentioned. That is somewhere in the measurement or a detection bias. Now was the follow-up sufficiently complete? Just looking at the follow-up rate, I will tell you the combined follow-up rate. So this is this is the Kaplan-Meier graph where each year and the cumulative incidence of exacerbation is given. Both of them started around with 13,000 people in each arm, and in 1 year, if you look at the non-gabapentin users, the attrition rate, or suppose if we are looking at 1 year, if suppose the incidence is 0.1%, then you can say out of 13,000 people, 0.1% had an exacerbation. That means 0.1% of 13,000. Suppose we take it as 1,300. We are supposed to have, then our follow-up is only till a severe exacerbation. So we are supposed to have after 1 year at least maybe 11,000 people in the arm. But however, we have only around 9,000 people. That means there was an attrition of 2,000 people out of 13,000. Almost 14% was the attrition rate in the non-gabapentin users. Now in a gabapentin user, if you look again, okay, suppose we grossly take again, this is also as 1%. Out of 13%, 1% having exacerbation will be again 1,300. So you are supposed to have almost 11,700 people in the arm. However, we had only 1,700. That means there was a significant decrease in the follow-up rate. That's almost 80% of attrition in the intervention group. And if you look individually also, the attrition rate in each in the gabapentin arm was significantly more than the non-gabapentin arm. So in the exposure group, there was a very significant attrition rate, and the follow-up was very low. Now, what are the results? So in results, things we need to look at is whether there is a strong association between the exposure and the outcome. Here we have done an adjusted hazard ratio in this cohort study, where if I take the overall cohort's adjusted hazard ratio, they have said in a gabapentin users 1.39 was the hazard ratio. That means if we had throughout the course of the disease, throughout the course of illness, gabapentin user had 1.39 times the risk of developing a severe COPD exacerbation compared to the reference or a non-gabapentin user. And the next question will be what is a precision. So I will explain this same slide. Precision we look when there is we look at the confidence interval between the two. Now if you look at the confidence interval in the overall cohort, it's between 1.29 to 1.5. Both lies on one side. How we can interpret this? So suppose we are talking about the overall cohort, we say the lowest confidence interval is 1.29. Whether is it significant to call something whether can we call it as a strong association if something is causing 1.29 times the chance, 29 times risk when we give the exposure, and whether it's significant if it's 1.5 times the exposure. So we take the both sides of the confidence interval and think. Suppose I am saying if we had a 1.29 chance of developing this, I sometimes would say okay, this may be a significant. Then 1.5 also I would say it's a significant. But suppose if we are coming to a under epilepsy arm, if you check at the hazard ratio, they are saying 1.58 also hazard ratio. And if you look at the confidence interval, it's from 1.08 to 2.3. Now, if you ask me if this drug has caused 1.08 times risk compared to a non-gabapentinoid user, I would say okay, this can be or this might not be very significant, just 1.08 times compared to the reference. But on the other side, it's 2.3 times. Now, if you ask, if I am saying this is causing almost 2.3 times a risk, then I would say yes, it's mostly significant. So, if I am taking individual in epilepsy, I would say the confidence level, even though it's on both sides, it's a wide range. So, maybe
it's not crossing 1.
It's not
108 is
on
this
this
side.
side. Yeah, but it's very close to the line. So even if it's if there is some benefit if I found in the end, and if it's causing only 1.08 only, I might say it's okay to continue this. But in the end, I'm not now. But if you're taking overall cohort, it's showing around 1.29 and 1.5. In both, in this wide, even the confidence is not very wide, and I would still say 1.29 is still significant. So it's about how we conclude what is significant and what is not significant. Here I would say in the overall cohort, the hazard ratio had a good precision with a confidence of 1.29, both were lying on the same side, and even if it's 1.29, I would still say it's significant. Again, so this was previously also done here, a Bradford Hill criteria. This is mainly the criteria to show that this exposure is a causation and not just an association. So now if we are go through this study for looking for whether this is a sole causation or just an association. Temporality means only after starting the exposure the outcome has happened. In this, we have looked only after starting a gabapentin. So temporality wise, yes, this is sufficient. Strength again. So strength is what I explained before. The strength of the association and outcome and exposure, which is in our study is a hazard ratio. But our hazard ratio is around 1.39. I'm not sure if there is a cutoff, but usually they say about 3.
Oh, 5 is a very strong thing, and the other way 0.5. But there's no magic rule. But generally 5 is by itself is odds ratio, hazard ratio 5. Oh, that means there's something significant.
So in this, it answers 1.39. So I would say strength as such might not be that significant according to the criteria. Biological gradient to look for the dose response rate. Someone only on 100 mg gabapentin had only this much exacerbation. Someone on 300 gabapentin had severe XR. Whether the study had looked at it, no, they have not classified it as people on low dose or high dose. So again, they could have done, but they have not done in this study. Consistency is whether there is the relationship is consistent in different studies and different population. So there are multiple. So if you look at the evidence, most of them are case reports and case series, where they have mentioned people on gabapentin has developed COPD and COPD exacerbations. In that, between 2012 and 17, there were all case reports saying breathing difficulties associated with gabapentinoid users. Then again, there are very few reports saying when the only causation suspected was a gabapentin, 26 of them reported the outcome was COPD exacerbation. But there are when multiple causes were evaluated, in that 73 of them had adverse effects. So gabapentin as such, again in 3 literatures also is not fully diagnosed as fully said as the only causality, only exposure that will cause this COPD exacerbation. It's not proven, and it's all case reports and case series, and the evidence also is lower. Specificity, again, single cause and single effect is also not yet proven, that only gabapentin will cause only this is not yet proven in any literature. plausibility, that is any biological relationship. The literatures, the only way of explaining this was gabapentin causing a respiratory depression leading to worsening of exacerbation of any respiratory illness, but no other explanation for a COPD exacerbation has been proven in any previous literatures. Coherence, again, the relationship is consistent with the previous knowledge, that in the previous studies most of them have said there are, but they are not fully consistent that only gabapentin will cause the effect. Analogy, this study is done on gabapentin and pregabalin causing the outcome, but there were no other studies I could find which were showing similar drug causing a similar effect. That is an analogy. We were not able to find much of literature on that. And last is experiment, where they could have either stopped gabapentin and shown that after stopping it they would have improved. So then again that will be a strong experiment wise. Once we stop the exposure, the outcome was improved. So that also they could have done, which is not also done. So if you do a Bradford criteria, the overall we are not fully sure to say the causality, it's a causality or an association. I mean, it's a causality because it's not fulfilling the criteria as such.
Yeah, just go back to that. Just to teach. So the important thing, if you are studying, somebody asks, does smoking cause lung cancer? Smoking comes before lung cancer. That we can see cohort studies. We know dose response. People who smoke 1 pack here have low risk of cancer, 10 pack here moderate, 30-40 pack here, so that's the dose response. Biological, the strength of the association, the odds ratio is 10-20 and odd for smoking and lung cancer. So it is something there more than just consistency. Everywhere in the world, smokers are higher. It's not that only few populations smoking causes lung cancer. Specificity is often a problem. Specificity is like mycobacterium tuberculosis will cause TB only. It doesn't cause lung cancer. It doesn't cause interstitial lung disease. So one cause, one disease. GABA use can cause many side effects. So you can't say it's only this, but that is a little odd kind of thing. Biological rationale for smoking and lung cancer, there is a theory. Nicotine breaks down into something, reduces some increases free radical damage, causes DNA damage, causes cancer. That is the biological pathway which one has to establish. So here also we must see whether we can make more than just respiratory suppression. Is there some biological mechanism? Then coherence with previous knowledge, what you have shown in previous studies. So that we have done. Analogy is like, hey, we know that not only smoking causes lung cancer, people exposed to some particular chemicals in a factory also get lung cancer. So this toxin causing lung cancer is a known thing. So here, are there any other drugs which exacerbate COPD or this kind of drugs?
Similar to gabapentinoids, I could.
So that's the other thing. Experiment in smoking is very interesting. People often say, how can you randomize people to smoking? Finally, you know what they did? They have a group of smokers. One group of people were given significant education, meaning every week the nurse will call them up, every time the doctor will call them up, drugs to stop smoking. The other group was given routine care, not told to continue, but every visit the doctor will say stop smoking. But the intensity of the stop smoking campaign was more in one arm than the other arm. And they followed them up and found less cancer in the people who must hold intensive smoking cessation. It's unethical to tell the other group to continue smoking. They did what was standard of care. So sometimes for harm you can do these kind of things, what you said, stop and see. They could have also seen in this kind of things. Yeah, go on.
Now the last part is, after this, how do I apply the result to my patient? There were the studied patients similar to patients in my practice. In our OPD we usually see COPD patients. They will be mostly diabetic also, and they will have neuropathic pain or any other cause of neuropathic pain. But according to this study, the mean age is around 73 with almost 50-56% female. Our COPD patients are mostly above 50 to 60 maybe, with almost equal or maybe more male predominant population of COPD we see because of the underlying exposures. Similar drugs we start, mostly LABA or LAMA more than short acting we start. Otherwise almost all the drugs also similar to what we practice. Comorbidity wise, diabetes is one of the most common comorbidity we see in our OPD, where there is only 36% in their population, and that will be the most common cause of all the, and that will be the reason why we will be prescribing this medication. But here it's lesser than what we see in our population. But otherwise, most other diseases or similar percentages to what we see in our OPD basis. Drugs like beta blockers again can have a worsening of respiratory symptoms. Again, not many of our patients, unlike it's a heart failure or anything, there is our population not much around beta blockers in our OPD also. Now, was the follow-up sufficiently long? So now our question is, we gave them an exposure and we are following up for the outcome. That we have to decide whether this much time is enough for the outcome to happen. Suppose we are looking at smoking and lung cancer, you can't follow them up for 6 months and wait for a lung cancer token. That should be or a longer follow-up to see he is developing. But here we are looking at a drug causing an outcome. I would say they have actually followed up patients for 1 year, 1.5 years for epilepsy arm, and the pain arm they have followed up for 1.6 years. And I would say, based on experience, I would say for a drug to cause an outcome, almost 1 to 1.5 years should be enough, because if the drug was supposed to cause it, they should cause within few days to weeks, I would say. So the follow-up in this case was sufficiently long. Is exposure similar to what might occur to a patient? Yeah, exposure. This is one of the commonest drug which we also prefer in our OPD settings. And what is the magnitude of the risk that is going to happen? So again, magnitude of the risk, we said the adjusted hazard ratio was 1.39. That means 1.39 times they could have a risk of developing an outcome. So here I would like Sir said, I would like to calculate the number needed to harm. For that we will need a absolute relative or a incidence rate. So this is not adjusted. However, I will just to show I will take the incidence rate. In the overall cohort, in a non-user, the incidence rate was 8.6% with a confidence of 8 to 8.6, and gabapentin user it was 15.1. So for an absolute change in risk, I would get around 6.8. That is the difference between the incidence in the intervention compared to the control group. Now, how to calculate a NNH or number needed to harm? I will divide it by 1 divided by the difference in the incidence. So that come to around 1 by 6.8%. So I will add 100. So 100 by 6.8, which is around 14%. So now the NNH here means if I treat 14 patients, 1 patient will develop a harm. Now, how to decide whether the magnitude is high or what is a significant NNH? Here our outcome is either a hospital admission or a death following an exacerbation. If I am treating someone for a neuropathic pain and out of 14 people, if 1 dies or 1 gets an admission, which is almost in our setting maybe almost 30,000 to 40,000 rupees one admission, including drugs and oxygen support or an I would say this is a significant number needed to harm. So, like Sir said, it depends on what is the outcome, and then we have to decide what is a significant NNH. Now, we'll ask the other benefits that are known to be associated with the exposure. Now, we are giving a gabapentin, or gabapentinoid, the most common benefits are one is which we give for epilepsy or the neuropathic pain. But if you look at all the literature, these drugs are more known for their side effects than their benefits. So there itself, we can say there are no active benefits, but side effects are more. When we look at the patient qualitative study also, they were all complaining more of lightheadedness, giddiness, increased sleepiness in the morning. These are more of the side effects they said compared to what the benefits were. Now, do we have an alternative for this treatment? Yes. We have actually have other drugs which we can use for like a tricyclic antidepressant or any other, there are multiple options we actually have for treating a neuropathic pain. Now we come back to our previous question, when a gentleman, chronic smoker, COPD came with a neuropathic pain to our OPD, do we actually have to start a gabapentin? Validity of the result wise, we have not fully found out whether this was a causation, and even there are some risk of bias also is present, the criteria in admission and all. There was some measurement by detection bias was there. However, in the end, if the NNH is 14 and our outcome we are looking at is hospitalization and death, I would say I would look for another option other than gabapentin or gabapentinoids in this time.
Fantastic. Let's give Renju a hand.